What's up, guys? Dr. Mo here, digital nomad physician at digitalnomadphysician.com. Welcome. So today I want to talk about it's more about getting back into kind of mainstream clinical medicine, especially urgent care and procedures. And a lot of the physicians who have specialties tend to actually be internal medicine or family medicine doctors. They just happen to be doing endocrinology, rheumatology, gastroenterology, or other subspecialties of internal medicine. I don't know if GI is subspecialty of internal medicine. I think it is, but there's sports medicine and there is hospitalist. And sometimes these physicians become so afraid of getting back into just good old primary care medicine, and they start developing a fear of all the different procedures that they have to do. So for me, the top three procedures that everybody's super afraid of is abscesses, so I&Ds, incision and drainage. The second one is laceration repair, sutures. And the third one is ingrown toenail. And then there's a few other ones like foreign body removal or fractures, kind of setting fractures. So I'm going to go through this one by one. The goal of this video is to help somebody who's afraid of like, oh, I don't want to get back into urgent care or primary care and like deal with those things. Even ER doctors will tell you that most of these things, most of the time when you're in the ER, when you're in the urgent care, you're not doing a lot of procedures. Most people are the standard worried well individuals who come, they're worried about something and you help rule it out. So let's get into that. My name is Mohammed Ashori, MD. I'm a board certified family medicine physician out of Los Angeles. You can check out my website at digitalnomadphysician.com. I have an online course for anybody interested in building their own online medical practice. And I do one-on-one coaching, consulting for physicians and medical businesses. So let's get into how to get over the fear of doing procedures. I think just zooming out, understand that a lot of abscesses are not really abscesses. They're just sebaceous cysts or epidermal cysts. They're epidermal cysts that people call sebaceous cysts, whatever. They're a collection of pocket of something tight under the skin. And they could be perirectal, they could be pilonidal, they could be in the gum, they could be on the skin. And sometimes they're already spontaneously draining. And when they're spontaneously draining, there's not a lot of benefit of cutting it. Of course, there are lots of opinions out there, and doctors will go toe to toe and fight each other to the bloody death about this. But understand that most of these things don't even need a whole lot of management. And then there's a lot of tricks. So one classic trick that I learned is to do a little bit of a subcutaneous numbing injection. Of course, now everyone's freaked out about, oh my God, subcutaneous numbing. How do I even do that? I haven't done that forever. How do I do a digital block? I haven't done that forever. We'll get into that. So you take, I always use diabetic needles, or I use a small 5cc syringe. I put a little bit of lidocaine. If you're afraid of epinephrine, you just use lidocaine without epinephrine. The percentage is less important. Most of the time I just use what we have. It's 1% or 2%. 2% gives you a little bit longer numbing time, which you often don't need. I use a 30 gauge needle, which injects very slowly and also retracts very slowly. So maybe you can use the vial and maybe use a 25 or even 18 gauge needle to withdraw the lidocaine into your syringe. Your medical assistant can do that for you as well. If they do it for you, be sure that they leave the vial next to the syringe, just in case there are some errors, and you can take a look at it and double check. And then if this is the skin, you're really just introducing the needle under the skin, right? You don't want to go into the subcutaneous fat or into the muscle because there's not a lot of nerve fibers there. The nerve fibers are here. This is the subcu fat and this is the muscle. And so you want to kind of go almost parallel, and I usually inject as I come out. And if you inject very, very slowly, introduce the needle slowly, the pain is often minimal. Of course, in the face and fingers, it's going to be more pronounced. Once you inject it, it gets numb really fast. And so if you inject over a sebaceous cyst or epidermal cyst or abscess, then one trick is you can use a punch biopsy, like a 5 millimeter punch biopsy, put a hole, and generally the abscess will come out. Now, if you go digging in there with some forceps, sometimes there's going to be some pockets of tenderness. You don't have to break up loculations generally, unless you feel all around and it's pretty bad. That's not common. I can't recall the last abscess that I drained, except when I was in the ER and I had a lot of IV drug users. You're not going to get a lot of that. And I don't even recall the last abscess that I drained. All of them so far have been epidermoid cysts. Because an abscess is really just more complicated. There's fevers, there's chills, and there's sometimes some cellulitis, especially with MRSA. So a little bit of lidocaine, punch biopsy, and if you want to do it the traditional way, you get an 11 blade or a 15 blade, and you just make a gentle cut. It's going to bleed. You make a little bit of a deeper cut, and then you can take your forceps, go into the cut, right? So here's the cut that I made. I take my forceps and I gently separate it, and just once enough pus comes out, I'm pretty happy. Of course, sometimes people make the tiniest little cuts. I don't understand why, because if you numb a nerve, that nerve has a branch, so it's going to kind of numb the entire area. And so you can get pretty aggressive with the cut. You can cut a little bit longer and go in and open it up. A big cut is not going to be any more complicated than a small cut. Are there any nerves underneath that you have to worry about? Are there any important structures? You'd have to get pretty deep to affect any of the major cutaneous nerves. Like up here, you got one that I think innervates the forearm. And then of course you have nerves over here. In near vascular bundles, I generally don't do much other than treat it very, very superficially. And if I'm kind of concerned, I'll send them to ortho, especially on the face. If it's kind of like in this triangle, I don't manipulate a lot of abscesses near the eye or anything like that. And again, I haven't seen those things, but I've had maybe another physician come to me and say, hey, Mo, what do you think of this? So guys, abscesses are not common. They're super easy to drain. To this day, I'll go watch a YouTube video on certain procedures that I do. I always just refresh my mind. Of course, the patient doesn't like that because they think that makes you incompetent, and they don't realize that that makes you quite competent to just reference things and listen to it. You can get a 5-minute super well done video and you can watch it on 2-speed and you'll know everything. Classically, I'll do that when I do an aspiration of a joint. Again, not common, and you don't even have to do it, right? You can send the patient off. The fact that you're in the urgent care and you can triage this patient and say, look, this is a very mild superficial infection. I think it might be an abscess. It's too small for me to even cut it. Let's try this. If you do think there is an abscess though, not cutting it, almost always it's going to cause problems. The patient's just going to come back. But sometimes the patient is absolutely against having any kind of incision and drainage. So, be mindful of that and document it really well. So that's the I&D. And I think, again, that's a big one. Sutures are another big one that people worry about. Most of the sutures that come into my urgent care or in primary care don't need to be drained. They're just tiny. They're super small. In fact, there's some good studies on it that suture laceration less than 2.5 centimeters doesn't benefit a lot from repair. Sometimes there's a cosmetic component to it. So for example, on the arm and the lower extremities, there's a lot of tension in the fascia. So if there's a cut and the fascia is cut as well, generally you have to suture the underneath fascia as well. You can't just do the skin on top, because otherwise the skin's just going to separate and you're going to get that kind of weird island looking thing in the long run. How many people are concerned about cosmetics? Not a lot. The people who bring up cosmetics to me, I always tell them the best place to be is in the emergency room, where you might get a plastic surgeon to come down and suture it. Almost never will that happen. Or they can, of course, have a few days for a laceration to go to a plastic surgeon to repair it. And so I give them that option as well. And quite a few parents, of course, worry because their kids might become models one day, or I don't know, some sort of aesthetic stuff that they're worried about, and they prefer to go to the ER, and they prefer to go. So lacerations on kids, pretty much hardly ever will anybody let me sew it up, because I tell them, I'm like, if you want a good cosmetic outcome, you gotta go somewhere where that's what they do for a living. That's what they do 24/7. So other things to worry about with lacerations is generally the bleeding. Once the bleeding is under control, if you can even put tension, what are they called? The steri-strip stuff. If you can put it around the wound, butterfly dressings, it will keep it under control. I've had quite a few lacerations, even over a joint, that I never went to a doctor for, and I never had any sutures placed. I'm not saying that's what you should do, but you can have that discussion with the patient. A good pressure dressing or Band-Aid will keep the tissue approximated, and it's going to stop bleeding, and it will help prevent getting it infected. The part about numbing that's important is sometimes you just need to inspect the wound. So learning how to do a digital block, and I generally just inject a CC here and a CC here. You can see where the nerve bundles are. Again, you can look that up on every single YouTube videos. You can do a nerve block here. There's a lot of different ways to do nerve blocks. And if it's, for example, here on the, let's say there's a laceration here, I'll just do what's called a field block. So I inject a little bit here, a little bit there, a little bit there, a little bit there. So here, 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 creating a square. And then that field is perfectly ready for me to suture up and do whatever I need to. If you're uncomfortable with sutures, again, watch a video. You can practice on banana skin, you can practice on orange skin, but it's generally, you're usually just going to have like a 3.0 or 5.0 nylon material, and you're going to have a very shitty suture kit. You're not going to have a lot of options. It's not like you're going to be able to be like, should I use a 5.0 absorbable, and then should I do like a 1.0 absorbable underneath? If you're already having to make those decisions and you're watching this video, it's probably better to send that person off to ortho walk-in like a ortho walk-in clinic or dermatology or plastics to get those things done. And of course, always the ER, right? If you think this is a more complicated laceration, for example, the vermilion border of the lip, right? I'm pretty comfortable suturing it closed and telling the patient, yeah, you might have some aesthetic issues in the future. Many patients will be like, no, my lips have to be perfect because, you know, again, Dolce & Gabbana is going to hire me tomorrow and I need it to be perfect. So yes, please go to the ER. That's where they're going to do it. Now, those patients usually come back and follow up with me in the urgent care, and the suture is exactly what you would expect. A super small 5.0 needle, a suture placed here and on top, and that's it, they're done. And they will do generally just a local block. They'll inject into the lip, which is painful, but that's just the way we do it. I can go more in detail about lacerations. I'll tell you that a lot of lacerations can be left alone with a discussion with a patient. Lacerations that are a little bit more problematic are over joints because they can constantly open up. And so for those, again, having a discussion of, hey, do you want that repaired? I've had lacerations, plenty of lacerations on my hands over my joints that I've just dressed, bandaged, everything's fine, and it repaired beautifully. And the last thing I want to talk about is it's ingrown toenails. Ingrown toenails, a lot of urgent care doctors or family medicine doctors or internal medicine doctors who go back into practicing primary care think that, oh my God, what if I get an ingrown toenail and those are so difficult to do? How do I do them? I used to feel the same way for probably about 10 years. I used to follow this horrible way that I was taught to do an ingrown toenail, which involved 75 steps and like a prayer. And it was absolutely, completely unnecessary until I watched a YouTube video by a podiatrist who did it so beautifully, so easily. And I'm like, why didn't I watch YouTube videos sooner? And for the most part, again, it's just a very simple procedure. You do a digital block here and massage the numbing medication, the lidocaine, under the tissue. Generally, you'll get a pretty good numbing. The way to test someone is to kind of poke them with something sharp. Don't cut their skin, just poke them with something sharp. They're always going to feel pressure. That's not going to go away. The pressure nerves are supplied somewhere else, and so they don't generally get numb. They're going to sometimes even feel a little bit of movement, but they're not going to feel something sharp. That's all that matters. And usually what I'll do is I'll begin the procedure very slowly, and if they're telling me like, no, I feel something sharp, that means I can go back and give them 20 more injections. They won't even feel it because that area is already pretty numb. So go back and redo it. Take your time. There's no rush. You can give the numbing injection, walk out, go see another patient, come back, massage, manipulate the joint a little bit. And then I'll go over the procedure, but again, I'll tell you why you probably don't even have to do the procedure. But generally, when I need to just cut out one edge of the nail, so I'll use something that's flat and I'll go and separate this edge of the nail from the nail bed, and then I'll use a scissor and cut. And generally, I have to go a little bit further down to about here because the nail bed or the beginning of the nail starts kind of down here, not here. And so I cut that out, grab it with pliers, twist it, forceps, and twist it and pull it out, yank it out. And that's pretty much it. Some people will put silver nitrate, some people will put some other aluminum solution in there just to kind of like cauterize it. yeah, I mean, you can do that. You can do a little bit of bacitracin and just pack it and wrap it pretty good, and you're done. And of course, your medical assistant should know how to do that. And that actually brings me to an important point. Is your urgent care or walk-in clinic set up for the procedures you're about to do? Is your staff comfortable with that? Is the next physician or PA or NP who's going to see this patient for follow-up in case you're not there comfortable with the management of any complications of this? If not, then you should not be performing these procedures. And it's perfectly fine to work in an urgent care or walk-in clinic and just say, this procedure, yeah, we could do it. It's going to be very time consuming based on given time and attention that I have right now. It's complicated. So I think there's a better place for you to go. And usually no ingrown toenail is an emergency. Almost never is a laceration an emergency, and almost never is an abscess an emergency. Well, let's say epidermal cyst is definitely never an emergency. And so if you decide to do the ingrown toenail for fun, you like the person, you want to help them out, sure, do it. But podiatry can do those very quickly and very easily. In fact, for somebody who's had recurrent ingrown toenails, a podiatry visit can be good because they can do some other procedures, such as removing excess tissue around it so that it doesn't come back. I'll say a last thing about fractures and foreign bodies. So foreign bodies can be in the eye, foreign bodies can be in the nose, foreign bodies can be in the ears, foreign bodies can be in the throat, vagina, urethra, and the anus. Those, obviously, foreign bodies you're not comfortable removing, you should never ever touch. But in children, they're going to put stuff in their ear, they're going to put stuff up their nose. If you're comfortable removing those, and if you know the tricks of how to do it, just do it. But otherwise, you can just kind of reassure the parent, like, hey, nothing dangerous is going on. There's not a battery that they swallowed. And you can kind of send them off to the ER for the ER to do it. Children's hospitals usually have a fast track for those things, and they can take care of that. Foreign bodies in the eye, that's a corneal foreign body. Generally, you should be able to see it with a naked eye unless you have vision problems, which is concerning if you're a physician. You can put the magnifying things over your head and take a look that way. Then you can use fluorescein if necessary. If you don't have a slit lamp, I advise you to not do a foreign body removal and just send that patient off to the emergency room. Other foreign bodies, rectal, vaginal, urethral. Urethra, the main issue is that if it's in there and it's stuck, you're not going to be able to remove it because maybe it's got barbs or something and it's stuck and you can't remove it. I know no one here is trying to remove any urethral foreign bodies. Rectal foreign bodies, if you can't see it, again, that's a bit concerning, but you can start the workup. You can get an x-ray, you can palpate the abdomen, you can discuss with the patient, like, is this something that might rupture? Is this something that might break? Is this something that might leak some sort of caustic material, right? And once you have that discussion, they can then decide what they want to do. And vaginal foreign bodies, so of course, that could be like a condom or retained tampon. Those are generally quite easy to do, but the patient's going to feel uncomfortable. So if you're already very uncomfortable doing it, don't do it. Send them to a gynecologist. But if you're comfortable, just to tell them, like, look, this is going to be awkward. It's going to be uncomfortable. I'm going to have to go digging around to find it. And you're going to be in stirrups. And we're going to use a speculum. And I'm going to look. It's not often easy to find. And if we do find a retained tampon, it's going to smell really strong. So don't freak out. We can take care of it. You got your baggie. You got your medical assistant hopefully helping you. So not terrible. Last one are fractures. So the most important thing that I care about with fractures is whether the person is neurovascularly intact. Don't let an orthopedic surgeon or ER doctor freak you out because they're going to come and tell you, you didn't reduce this fracture, you're incompetent, you don't care, you don't know what you're doing. It's not true, okay? There are definitely fractures that need to be reduced, but there are certain fractures that you're either not capable of reducing, or once you reduce it, you don't have the means to put it in the right splint for it to not retract back into the previous position, and you need to get multiple x-rays. If you've ever spent any time in the fast track of a fracture clinic, it is a mess. It is an absolute chaos, but it is an organized chaos. They're doing traction and they're pushing and they're pulling and the patient's screaming and they're doing hematoma blocks and they're using fiberglass cast and then redoing it and getting an x-ray, bringing a PA, having another NP look at it, having the orthopedic come. It's chaos. So there is no beautiful way of saying it. Anybody can look after the fact and say, Dr. Ashori did a shitty job. He should have reduced that Colles fracture of the wrist. That elbow fracture should have been reduced. The humerus fracture should have been reduced. Okay, if you have any doubts and if you don't like somebody second guessing your work, just send them to the ER. The ER usually has a fast track, so the patient rarely will wait the normal 6 to 10 hours in the emergency room. If they have like a medical condition, yes, they might wait a lot longer, but the fast track usually takes care of lacerations, fractures, and abscesses pretty quickly. So sometimes when you do have a deformed joint, it's just dislocated, so get an x-ray first. And obviously sometimes it's pure, like absolutely fractured, and you may not be able to tell. Somebody comes in with ankle pain and sprain symptoms, you get an x-ray, they got a trimalleolar fracture. So if you don't know, just get an x-ray, take a look at it. Okay, we got to put you in a cast and a walking boot and some crutches, and you're gonna go straight to ortho. If they can't go straight to ortho, you send them to the emergency room. What you check for is, can you feel me touching this area? Great. Can you feel me moving this area? Great. Does the patient have good pulses? And again, just compare it bilaterally. If in doubt, there's been plenty of times where I couldn't feel a pulse, but it was perfectly there, and I just didn't have a Doppler in my clinic, so I sent the patient to the ER. The ER doctor calls me, Dr. Ashori, why'd you send this patient in? They had perfectly good pulses. Well, I didn't feel them, so they didn't have a pulse. That's all I care about, right? Use your judgment, trust your judgment, and over time, your judgment will improve quite a bit. I hope this is helpful for physicians who are interested in getting back into primary care, getting back into the urgent care, and just lose the fear. You can always call a friend. You can call somebody to come into the room with you and take a look at stuff. And you can always send the patient off to the ER and then call them back and say, hey, what did they do at the ER for you? And just learn from that. Take care, guys.